We are live.
Hello, everybody. A very warm welcome to everyone to this AIOS IOC International Conclave. We are entering into the MIGS session, the minimally invasive glaucoma surgery, when and how. We know MIGS has really revolutionized the way we're treating glaucoma these days, and we have an array of stalwarts and illustrious speakers ahead of us. I am the session coordinator, Dr. Sahiba Sethi. I practice in Arunodaya Desert Eye Hospital in Gurugram, India. I'm going to now introduce Dr. Harsh Kumar and Dr. Satyan Parthasarthi, who are illustrious leading glaucoma specialists in India, and they will be taking over as chairpersons. I also want to invite Dr. Sushmita Kaushik as the moderator to come upon and take on her responsibility from here on. I will be a silent spectator. The stage is on to you, ma'am.
Thank you, Saiban. And I think we can go ahead now. At the very outset, I want to thank Dr. Santosh, who has been so kind as to give us this opportunity, because what a gem of a faculty and the panel that we have got over here. And basically, anybody who has had dealings in glaucoma knows that we have had enough of trabs. Most conjunctival surgeries are a little a bit of pain. We have to do them for any advanced glaucoma. Yes, that is the answer. But any surgery which will delay trab or which will we can be a substitute for trab will be great. And that is where the MIGS come in. So the very first time that the MIGS trickled into India, my CEO came to me and said, "Why don't you try these stents and all?" And I said, "Oh my God, but they are so expensive, and it may be not so easy to do them." And then she smiled and she told me, "Well, Dr. Kumar, if you don't do them, how will you know whether they are good or they are bad?" So that is the truth about the angle surgery. For every young person, they will have to learn it because the future is going to belong to the angle surgeries. And for every person of my age, if you want to be in the game, if you want to offer the best to your patients, that is what you will have to learn. And if at my age I can learn an angle surgery sitting hours and hours, and therefore any one of you can do it, and as a matter of fact you will have to do it, that is where the future belongs. So I don't want to stand between you and the august faculty. I hand it over to Shushmita to please take it on. Thank you.
Thank you. Thank you so much, sir. And at the outset, thank you again, AIOS, and my friends who've all agreed to come on board at just one invitation. I thank you from the bottom of our hearts. So today's session, we know, will be chaired by Dr. Harsh and Dr. Satyan. And as panelists to lead the discussion, we have eminent glaucoma surgeons, and I'll just run through Dr. Kirsten Klabe from Germany, Professor Pandav from the Advanced Eye Center, PGI, Dr. Tanuj Dada, the Head of Glaucoma Services at RP Center, AIMS, Delhi, Dr. Sunita Dubey, Head of Glaucoma Services at Shroff Charity Eye Hospital, and Dr. Siddharth Dikshit from LV Prasad Eye Institute, Hyderabad. So the session that we have is divided into 4 talks, and we'll then have 4 interesting cases with perspectives from around the world, followed by discussions. Faculty talks will be delivered by Dr. Conrad Shargil and Dr. Gorka from King Khalid Subspecialty Hospital, Saudi Arabia, Dr. Ganesh Venkatraman from Arvind Eye Hospital, Coimbatore, and Dr. Shamira Pereira from the Singapore National Eye Center, Singapore. And the 4 cases will be presented respectively by Dr. Yap Julie from Singapore, Dr. Swati from the Arvind Eye Hospital, Dr. Judy Koo from Brisbane, Australia, and Dr. Sushma Tejwani from Narayana Nethralaya, Bangalore. So it's my pleasure to now hand over the session to Dr. Conrad for the first talk, please. If you could share your slides. Thank you.
Thank you, Dr. Shushmita. And as you mentioned, as a good friend, it's very hard to say no to you to any kind of invitation. So I will mainly talk about where I fit my MIGS in my glaucoma surgical plan. So there is no financial disclosure in this talk. And when we talk about the history of the MIGS, and if you pass it and put it according to the timing, we can see that there is a huge evolution regarding the MIGS. And mainly, as Dr. Kumar mentioned, the essence of the MIGS are the minimal traumatic and the favorable safety profile among these 5 characteristics. And this is what it makes MIGS so popular nowadays. Where the MIGS move? The MIGS move in between the safety, high safety profile of the drops and the high efficacy of the tubes. Right in between is where the MIGS are supposed to be moving right now. And the target area is basically to get this Schlemm canal that Johnston proved that basically is not just a simple tube. It's a live device that moves according to the level of pressure inside of the eye. And that ocular blood flow through that system that includes the anterior chamber into the Schlemm canal into the collector channels, and the collector channels into the episcleral veins. What are the prognostic factors we have to keep in mind? Does the MIGS works in every case? Well, certainly in patients that has very high pressure, MIGS are not the ideal one. And when we get pressure to certain limits, and probably better to say patients that are well controlled with medication, those are the target, especially if they are going to be combined with cataract surgery. There are signs in my experience that make it elevate the prognostic factor and say, well, this is going to be a successful case, which is the full flow of blood of the Schlemm canal once you finish the cataract surgery. And I classify them. If you see that the Schlemm canal it's patchy with blood, it's always better to target these areas that has full of blood. When I started with the MIGS in Spain back in the 2006, it was only on experimental basis. We were participating on multi-center studies. And at the beginning was not our main surgery, but once 2013 that was commercialized, mainly was the eye stent, it became in less than 2 years, it became the most popular surgery. That it was also based on the type of surgical patients we have. But coming back to Saudi Arabia, since 2018, it's not my main popular surgery. And the main reason is because the cases are not suitable for angular surgery. So case selection is very important. And here is the main part of my talk. This is the surgical algorithm I applied for 2025. And I will divide the MIGS into MIGS and MIPS. Shen and pressure flow are not in the same group, at least from my perspective. And there is people that is going to talk about these 2 devices. So minimal invasive glaucoma surgery are those ones that you can really use in the angle, at least from my concept part of view. How we select the device? Well, first we have to have the target of the IOP we want, safety, the number of medication the patient is used. Some of these devices has better evidence in long terms than others. The idea is to slow down the progression and delay a second surgery. All of our glaucoma patients are going to have probably further waves of treatment. So what we are trying to do is improve the quality of life. It's modify very little the refraction and spare the tissue for the future possible surgery. And of course, what we have available in this case in India, for example. The success will depend on choosing the right patient, as I mentioned, on the characteristic of the angle and doing it in the right way. What are the best surgical patients for trabecular surgery? Well, open-angle glaucoma, pseudosfoliative glaucoma, pigmentary glaucoma, mild to moderate, pre-op pressures not more than 30s, and the objective target pressure, at least 16 to 18. Patients that are pseudophakic or are going for cataract surgery are ideal. Patients that has problems to apply the treatment, size effect related to this topical treatment, compliance, angle should be open and well seen, and no synechias. So a lot of our old elderly patients has reaction to the medication or incapacity to apply the medication. So these are good cases for it. Anomalies in the angle are, of course, patients that shouldn't be considered for angular surgery. We have to look patients that has small anterior synechias. We could try to release these synechias or use spare areas. Are not the ideal, but it could be used right now. So in this case, for example, you can see that the left eye, it's absolutely in a more advanced. This is not going to be a suitable case for angular surgery, while the right eye is starting to have compromise in the ganglion cells. So it's a case that probably I will choose another technique than filtration. I will go more for an angular surgery. Avoid any scleral condition that could compromise this angular surgery, as this case of a scleromalacia in which it was inserted an eye stent, and of course, migration and lack of tissue that will support will make it not work. So tips to start: look for the angular structure, position of the microscope, position of the patient, and angular lens. I'm going to mention very few things about this. This is the target area. We have to target them on the angle, the filtration area. If we go in another way, in another place, this is not going to work. So how we recognize the filtration area? Blood presence in the Schlemm canal after the decompression. This will appear in about 80% of the cases. This is a good sign, as I show in the previous picture. You can see that while gonioscopy is so important technique in the office is a must, but they are not exactly the same during the surgery. But you can find some references. Whatever you see in the office, like an open angle, then you can really say, well, this is a suitable case. And the only condition that it will make the difference will be once you get the blood in the Schlemm canal. Lenses, there are many. Microscopes, there are many that you can adapt to the technique. And the only condition is that most of these devices right now needs to use the non-dominant hands for seeing the angle. This is a two techniques hands, so you have to be very comfortable holding the eye with the lens. We have now devices that can be adapted to the lens system, similar to the BIOS, like this lens from Oculus, and that keep us our two hands free just for the surgical procedure. And it gives us a good view of the angle. It's expensive probably because it's a single use, but it gives us the good opportunity to have a clarity of the angle. It's very important to have a perfect view and avoid the bubbles that it will be created by the pressure of the lenses. We don't only have the eye stent, of course. We have techniques that, like the Cahook dual blade and the needle one that we use to scrap the trabecular meshwork also work in a similar way. And dilation of the Schlemm canal has, most of this technique has a similar action, and the decrease of pressure is about the same. It's about 30%. All depends how comfortable you feel with each technique and which one you had available. And we always have to think that while we are doing these procedures, we're not only doing the cataract, we're doing two combined surgeries. So even the building of our incision must be related to the second surgery you're going to be doing. In this case, is a ABIC procedure. Sometimes, of course, during angular surgery, we have problems to have a perfect view of the area that we're going to be treating. In this case, you can combine with IA aspiration or viscoelastic injection. And as you can see, the evidence show that most of these angular surgery work about the same, about 30% reduction from the basic IOP. One important thing is how this will affect the endothelial cell count. It seems that there are devices that affect more the endothelial cell count, like it was with the CyPass that we know that is out of the market right now. And we have to be careful with all of these techniques, special ones that we are leaving something inside of the eye. So in summary, angular surgery has in common about a reduction of 30 to 40% of the IOP, decrease the number of medication on 75%, and this is very important because improve the quality of life, plus improve the condition of the conjunctiva for the future surgery that this patient might need. At least the studies show that 3 to 5 years, 70% of the patients are well controlled and with lack of medication. The endothelial cell count still under observation, and we have to be careful on this. At similar outcomes, choosing a technique by simplicity could be a wise condition, and selecting the patient and time of surgery is of key importance. Take the time to observe and localize the landmark in the angle. Step for the correct implantation must be followed, and there are some maneuvers that can be used to optimize the area of implantations as well as should be used before trying to the attempt. Thank you very much.
Thank you so much, Dr. Conrad. That was such a lovely overview. If you could stop sharing, please. So I just want to start the discussion with asking one question that you said long-term medication use would be one indication for doing MIGS. Do you think it would affect the outflow channels like it affects the conjunctiva and affect the outcomes if somebody is on? Because we tend to see that when you have very, very bad ocular surface, somehow the MIGS don't work as well as we would like it to. So what would be your take on that?
I am absolutely agree with that statement. I think that the use of long-standing use of medication will affect the outcome, for example, of filtration surgeries in the future. I'm not sure how could that affect the performance of the MIGS. For me, the more important indicator than the conjunctiva for the MIGS procedure is how is the Schlemm behaving right after, for example, a cataract surgery. So if I have a field lab of blood, I know that the Schlemm canal is working. So I will target that part. Probably the conjunctiva is more affected because the long.
I think we've lost your connection.
Veins probably will not be affected that much. While the long-standing use of medication. Sorry, did you hear me?
I think the internet was a little patchy, so now it's better. Now it's okay.
Now it's better. So I think that the conjunctiva itself will not be a condition that will affect the performance of the MIGS, as is affecting the performance of a filtration surgery.
Okay.
Pressure flow shunt, I'm not included in this group. Those are going to be affected by the state of the conjunctiva, in my experience. Yeah.
Yeah. So we have a talk on when would I do which MIGS. So we leave that question for later. I think in the interest of time, we'll go on to Dr. Ganesh. When would I not do? And I have a question up my sleeve, but I'll ask it after you give your talk pertaining to when would you not do MIGS? Dr. Ganesh.
Yeah, yes, madam. I'll just share my screen. And at the outset, I would like to thank AIOS for providing us this opportunity to speak to you. Okay. Just a second. I'll just hide the floating panel and come on to the big screen. Am I visible now? Am I slides visible? Can you hear me?
Yes. Yes. Go ahead.
Okay, thank you. So where I would not do it, MIGS, that's the situation. And like to thank you particularly for asking me for this talk, and thank you once again. So we all know we have certain demerits of MIGS. First of all, it's not modifiable. You cannot increase the steroids and make it work, pun intended. And it's suitable for mild to moderate glaucoma, as you just heard. And many of them, the labeled indications are primary open angle glaucoma, mild to moderate. And as a disclaimer to this talk, I do all MIGS, including KDB, GAT, eye stent, tinnitus. So having said that, we have, as Dr. Conrad has also mentioned, we should plan what the MIGS based on what is available in our country. So you have a huge list on your left-hand side. You see the proprietary devices. And then you have the similar generic equivalents, which we have in India. And some of them, like the tinnitus hooks, are reusable. So MIGS, usually in our practice, we will preferably avoid if you have angle closure disease or advanced POAG, pseudoexfoliation glaucoma, neovascular glaucoma, trauma and angle recession, silicone oil-induced glaucoma, angle dysgenesis like eye syndromes or Axenfeld-Rieger syndrome, corneal dystrophy where you cannot see the angle at all. Some hematomas like nevus of Ota, Sturge-Weber syndrome, where I think some speakers are going to talk some alternative techniques for that. And we also avoid it where you have additional procedures which are required immediately. Supposing you want to have a media clarity after the surgery, because as you know, some of the MIGS, especially GAT or excisional MIGS, they can cause severe bleeding. And if you want to reset the anti-glaucoma medication clock for the patient, or if you have a pediatric patient who requires multiple GA sessions or a vulnerable patient who requires multiple GA sessions, they are again, because if it becomes unpredictable, then you have to take them under general anesthesia and operate them again. So let's talk an example. So this patient, patient SF, so he presented to us with reduced vision in the left eye for 2 years, but more than that, he was apprehensive about the right eye, for which he started losing vision for 8 months. And he had a documented history of proliferative diabetic retinopathy and had developed neovascular glaucoma in the right eye. And he had a vision acuity of 6/60 in the right eye, no PL in the left eye, and intraocular pressures, both eyes, 26 millimeters of mercury. So anterior segment, we saw NVI in grade 2, grade 3, PS with PSCC, and left eye was an absolute eye, and he had 360 laser marks. But for the right eye, the adequacy of the laser marks was suspect. So, and this is a gonioscopy findings, it's totally closed angle. To rehabilitate him, we have to access the retina very quickly. So you need retinal ablation and to arrest the neovascular process. So we planned for a combined cataract and glaucoma surgery for him, which is generally what we do. And the surgery was uneventful. He had very fast rehabilitation. And you can see the picture in the right eye, for which he underwent adequate retinal ablation very quickly. So this procedure provided a clear media, and he was rehabilitated very well. The left eye, of course, we could not do much. We did a cyclophotocoagulation for him later on. So the principle in management of neovascular glaucoma is to access and visualize the retina ASAP to make it an anoxic retina from a hypoxic retina. So if we were to do something like a mixed procedure, and if there was excessive bleeding, we would be delaying his primary treatment. This is another situation where we had a silicone oil glaucoma. For example, this patient had radial keratotomies in both the eyes, and he had a retinal detachment in the left eye. Underwent a retina surgery, and post-SY he developed a cataract and glaucoma, for which we proceeded to do a GAT with phaco, and this is the result about 10 days out. He had IOP of 11, but unfortunately his IOP started spiking, and he was put on medication at the end of 30 days, and he was unfortunately lost to follow-up. This is fundus. And you can see when he came back after about a year, his visual fields had dropped drastically, and he had to be, aggressively treated to stabilize his visual field. So that's the mark which shows in where he underwent the surgery, and the visual acuity, visual fields dropped significantly over a period of 1 year. So IOPs tend to fluctuate, in many of these patients, and we should be aware of that. Keep them in close follow-up, especially if you've done a MIGS procedure in such patients. Trauma and annualization, again, they are not very ideal situation for a MIGS procedure. You have a paradoxical IOP response. They really need a modifiable procedure. They invariably happen in young patients and who require multiple GA sessions. And therefore, conventional surgery is much more recommended in such eyes. And also, they may be associated with very high IOP, and you may have corneal edema, which obscures the visualization of the angle. So this patient, this is something which we face on a daily basis in India. Patient SMA. She presented just recently, about 3 months back, 32-year-old female with PACG. And she was phakic, IOP of 30 both eyes. Angles were near closed. She was on 4 medications. We advised surgery for the worst eye. She disappeared. And she came back again in the month of January, stopping medication for 1 week. But I bet, it could be a month also. And this is how a disc looks, very pale and just at the age of 32, and this is a visual field. And you can see that in such situations, a MIGS is definitely not an ideal situation, even if you were to knock off the cataract or the clear lens. So we immediately proceeded with a trab with MMC. She did well after that. And we're planning for the same thing for the right eyes as well. So angle closure disease is a strict no-no for MIGS, and we have 50% of patients present with angle closure disease in India. Another lady, 74 years and hypertensive, visual acuity is very good, and phakic. Left eye, she developed pseudoexfoliation glaucoma. Angles were open, and this is how you look at see the fundus. It's a bipolar notch in the left side. Right eye is pretty good. So unilateral pseudoexfoliation glaucoma, and this is a OCT. So very advanced damage in the left eye, and these are visual fields. So we went ahead and we did a conventional trabeculectomy for her, and she did quite well after that. So this is again a strict no-no for mixed advanced glaucoma, pseudoexfoliation, elderly patient who has to be stabilized very quickly. Another situation like angle Axenfeld-Rieger syndrome. He's a 30-year-old male patient with a special individual with hearing and speech challenge. Visual acuity is 624, both eyes. And instead of, we were able to visualize the angle, but we performed a canaloplasty for the right eye, and we are awaiting canaloplasty for the left eye. So these eyes, although one may be tempted to do a MIGS procedure, it's better to always do a conventional procedure and then build on it rather and rehabilitate them. So the lens ultimately underwent extraction, and the intraocular lens was implanted. So if you distort the angle in eye too much, then it's very difficult for the subsequent surgeon to rehabilitate these patients. So I'll come to this scenario. We have siblings, a 12-year-old and a 9-year-old. And when they first presented to us, they had a family history of glaucoma in the sister and mother. Mother had undergone trab, so she was aware of the situation. But unfortunately, she could not take care of her daughter, who was elder to both of them, and the daughter was blind in both eyes. But the children, as they grew up, the boys, she brought them to us. And the intraocular pressure for the elder one, who was 12 years old, was 32 millimeters of mercury. The younger one had normal intraocular pressures. And this is the elder sibling. You can see the disc at presentation. It was good, but during COVID, they were lost to follow-up. So they came somewhere in 2016, and we were treating them. The elder sibling, we already advised surgery, but they neglected, and they went off and they came back after COVID, as I'll just show you next. And you can see the progression in the visual, in the OCT as well as the disc. And this is the timeline for the patient. So you can see we started glaucoma medication. They were doing well before COVID, and we advised surgery just before COVID, but they came back after the first wave. And by the time the intraocular pressure had shot up very high, and we did a canaloplasty for both the eyes for the elder sibling. After that, for the last almost 3 years out now, he's doing pretty well with the normal intraocular pressure. That's for the elder sibling. Now the younger, this is the field for the elder sibling. So he progressed pretty fast in those 5 years' time. The younger sibling, he was normal essentially, and just before COVID, his IOP spiked. So we started on medication, and we also advised surgery because we knew what's going to happen to the brother. They were coming almost on the same day. And for him, we again, they were lost to follow up. And after COVID, we did a GAT procedure for him. And then that worked well. And now both the siblings come together and they're doing pretty well. And this is his disc features. You can see that quite a significant progression has occurred. And that's a visual field for him. Thankfully, it has not deteriorated. So the elder sibling underwent a filtering procedure of both eyes, and the younger sibling underwent GAT procedure. So 3 years out, nil medication with stable fields. So this is a series of patients we published, and some of the conditions where we avoid is hamartomas, for example, nevus of Otta and Sturge-Weber syndrome. Again, another situation where we avoid MIGS is where we prefer to do a conventional trab or a non-penetrating deep sclerectomy is viral uveitis. You can see the patient number 4 and 5. At the end of 1 year, they had IOP of 28 and 40, whereas the other patients who underwent GAT, they did well after the procedure at the end of 1 year. So case selection is extremely important. So in summary, I would like to be gratitude to our patients, our international national colleagues, device manufacturers, regulatory authorities, providing us a lot of benefits in terms of our ability to treat our patients much better. But we, at the same time, we should be very careful about the vulnerable population, women, the elderly, children. Sometimes they require repeat procedure, and knowledge of surgery may not be an indication of surgery now in glaucoma, mainly because glaucoma surgery has become something like a precision medicine. Thank you very much.
Thank you so much, Dr. Ganesh, for that overview. And I'll straight jump into controversy and throw it open to Professor Pandav and Professor Tanuj, because he said angle closure is an absolute no-no. And with half our patients with primary angle closure glaucoma, Dr. Tanuj, you can take it first, and then I'll ask Professor Pandav to follow it up. Would it be a strict no-no for angle closure glaucoma?
Actually, now there are some studies published from Hong Kong and China which have evaluated the effect of MIGS in angle closure glaucoma. So I think for early stages of primary angle closure and early primary angle closure glaucoma, once you do a phacoemulsification, I think you can go ahead and do a goniosynovial and do any of these surgeries on the trabecular meshwork to open the canal. So although the efficacy may not be as good as primary open angle glaucoma, but there is evidence to suggest that minimally invasive glaucoma surgery has a role in primary angle closure glaucoma, especially in the early stages. And as far as advanced glaucoma is concerned, like we have access to the endoscopic cyclophotocoagulation at RP Center. So instead of doing a combined phaco trap where the long-term outcome of trabeculectomy are not so good in combination surgery, so their phaco combined with the endoscopic cyclophotocoagulation is also an option, and it is classified as one of the MIGS surgery. So I think definitely, yes, I would say there is now an upcoming and an increasing role of MIGS in angle closure as well. The only thing is we have to do a preoperative goniosynovial to expose the TM if there is synechia in the angle. Thank you.
Dr. Pandav, so your take on it?
Yeah, I kind of tend to agree with Tanuj that angle closure is not really a strict no-no for MIGS now, especially when you are doing procedure where you are stripping off that trabecular meshwork. I mean, eye stent might be a little issue, but other procedures they can be done, especially you're combining with the cataract surgery. One can argue, and as Tanu said, that you could open up the angles by bit of goniosynovial, and once removing the lens, the angle actually opens up enough to put to do the procedure. One can argue that the IOP reduction that you're seeing is it just because of cataract surgery, or is your MIG procedure playing a role in that? I think that thing can be debated. Because in angle closure, we know that if you are removing the lens, the angle opens up and the IOP reduction would be expected in those eyes. And over and above that, how much is your MIG procedure contributing? Now, there's no clear answer to that, but I think the general the impression is that it does lead to more IOP reduction if you have a MIG procedure along with the cataract surgery. We have our own experience. I mean, we have done some, MIG cases, especially the bang-like procedures in angle closure, and we have seen a good IOP reduction following cataract surgery in angle closure. So I think this procedure can be done with closure. Of course, you have to like choose your patients with not extensive synechiae and that kind of thing.
Can I get a rejoinder on that?
Yeah.
Yes, please.
So you could always, reduce the pressure and then do a mixed procedure as a subsequent procedure also. If you are not very keen on removing the cataract the first sitting, if the cataract doesn't exist, you can always do a mixed procedure after you've done a trap. So that also works very well if you were to do a cataract with a bang or a cataract with a GAT. That option also exists. Primarily, you have already reduced the pressure to a satisfactory level. As the glaucoma progresses or the trap fails, you could come back and do that as a second procedure as well.
Just sharing one small thought that is possibly coming on with all of us who do MIGS in angle closure is that possibly angle closure is more a trabecular meshwork problem. And compared to the POAGs and GOAGs where the outflow is completely gone as well. So maybe that might have some explanation as to why, especially the trabecular stripping procedures seem to actually work quite well in angle closures. But I think moving on to just one quick thing about the indications, and then we'll go on to which for whom. Dr. Sunita and Dr. Siddharth, I'd like a quick rejoinder to, do you really think secondary open angle glaucomas might actually work better because of the same problem, say steroid induced or uveitic, because it's a primarily trabecular meshwork problem? So do you think having better outflow might work better? Dr. Siddharth, if you could take that for steroids, for uveitis, for even trauma, would you consider MIGS in them rather than just have primary open angles?
Yeah, I would. My answer to the question would be yes, with the caveat that there are the other contraindications that we discussed in the previous presentations. If the intraocular pressure has been very high, if the disease is very long-standing, if the number of medications is very high, then the chances of the success drops a little bit. But especially for the recent onset secondary open angle glaucomas like the pseudoexfoliation, pigmentary glaucoma, steroid-induced glaucoma, they work quite well. Trauma, I've in my experience, if the intraocular pressure to begin with has been very high, I think there the situation becomes a little dicey. But yes, for the other situations. And one small comment about angle closure, if you allow me to do it. The angle closure disease is a wide spectrum. And in many patients with primary angle closure and primary angle closure glaucoma, especially when it's early stage, you have quite a bit of the angle open. Yeah. So maybe not implanting a device, but an excisional goniotomy approach MIGS, we can definitely take advantage of the relatively well-oiled distal outflow pathway.
Yeah. Dr. Sunita, a quick comment, then we move on.
Yeah, so I completely agree with Siddharth. Like, it is quite effective, and I have got a lot of experience in recent onset secondary glaucomas, which we call the proximal glaucomas, because the distal collector channels are still patent. So as he rightly mentioned, if the secondary glaucoma is of recent onset, it's not very long standing, then it is kind of proximal glaucoma, and all these procedures work very well, the KDB, BANG, and GAT. So they work really well. And even in trauma, I have done a few cases wherein it's a short, not long-standing trauma, and associated with, a rupture of the anterior capsule and subluxated cataracts. So in those cases also, it has worked very well. So in my experience, yes, secondary glaucomas, it really works very well.
Thank you. So we move on now, and I think Dr. Gorka Sesma will tell us how would I decide which MIGS for whom.
Thank you very much, Dr. Susmita. Thank you for the invitation. Thank you to the IOS for the invitation. Well, I feel a little bit shy in the middle of this outstanding forum and an expert being pediatric ophthalmology. But let's see how can I do it. We decided to, when we discussed about this lecture, I decided to bring this case just basically because it's a controversial I wanted to bring it to all of you that you're experts to see what can we get at the end of this one. I don't have financial disclosure, so I'll present the case of Sturge-Weber syndrome. And as we all know, Sturge-Weber syndrome is a rare disease, but terrible disease with systemic implications, with life expectancy situations. And the most important part is that we have affection, we have glaucoma, secondary glaucoma. So high incidence, and the treatments that we have, the gold standard of the treatments that we have already are not quite good. The outcomes are not quite good. So based on that, we face some challenges in these cases. One thing that we face is the amount of huge changes that the eye in the kid happens, especially during the first year of age. So we have anatomical changes. We have also elevated surgical risk using the gold standard treatments. And that's why I want to present you this case. This case is a baby girl of 10 months old with a Sturge-Weber syndrome, with systemic implications, history of seizures, treated because of the seizures, and presented to our clinic with glaucoma. So we decide to use a pressure flow in this case. What it was the purpose of this one? After huge discussion with the parents, and after a deep discussion with Dr. Sharhel, we worked together in KKESH. He's the chief of glaucoma, I'm the chief of pediatric. We sit it together and we decide, what about if we can buy some time for this baby, knowing that the standard treatments are not quite good. So after the approval of the parents and after discussing these options, we decide to proceed with the pressure flow. As all of you know, this is a summary of the pressure flow. And as was mentioned briefly before, these are the characteristics. So we decide to do the procedure. The procedure was performed by Dr. Sharhel. We did it at 5 weeks of age. And we made some modifications compared with adult pressure flow surgery based in the anatomy changes, based in the growing factor as a factor that can induce good or bad outcomes. And the surgery was as a regular surgery in adults, and we placed the pressure flow in the supratemporal quadrant with a report. This is a surgery by Dr. Sharhel. We do the peritomy, we use mitomycin, we dissect the conjunctiva posteriorly. We place the tunnel at 2.5 millimeters. That's the first difference. The recommendation is at 3.5. We put it at 2.5, considering that during the first year of age, the eye grows and change a lot. So we place the pressure flow, we fix it to the sclera, and after fixing to the sclera, because the growing, because the moving, because the rubbing, because the situations, we place then a ripcord to stabilize the IOP in the immediate post-op. The surgery is the similar technique that in adults. The issue is that we place the ripcord more anteriorly than usually, and we take care to close very, very well the conjunctiva to avoid the leaking and knowing the changes or affections that can produce a bad closure of the conjunctiva. So after this procedure, the patient immediately start having good control of the IOP. 1 month and a half later after the surgery, we decide to remove the ripcord because the IOP was starting to raise. And we have an issue. 2 months after the surgery, we have to reoperate the patient because the lumen of the tube was blocked by iris. So we decide to go back 2 months later after surgery, after the patient had reductions of 40% of the IOP. At that moment, when we observed this patient, the IOP was raising. So we enter in the surgery, and you can see the surgery Dr. Sharhel and I, we were together in the surgery. He entered, he tried to flow the tube. Then with the spatula, he removed the iris from the lumen of the tube. And when he checked again, you see the pupil how went the position. We did gonioscopy, and we observed that there was a fibrous tissue in the lumen of the tube. So he decided to enter and remove the fibrous tissue. Immediately after he removed the fibrous tissue, the patient developed IOPs of 10. So we followed this patient for 32 weeks. And after this procedure and after this specific complication that the patient had, the patient until now is actually 12 months of age, is doing great and wonderful. This is a summary of the timeline. And I would like just to mention that we have the tendency to talk about IOP, but in childhood glaucoma, I think that the childhood glaucoma is everything but IOP. You could find more than 80 variables that can be assessed, evaluated, and can give us better picture of the disease. Goes far away beyond of the IOP, and you can see some of them. In this specific case, you say how the parameters were raising, specifically the IOP was raising and that's why we take the decision to remove the report. And as you see how in the pressure in the second line, you can see how the IOP was raising to 27. So that's why we took the decision to remove it. When we go deep in these issues, you can say how the horizontal corneal diameter was affected. Also, how, sorry for a moment. I have a problem here with my screen. Speaker. Oh, sorry. I wanted to see, I lost my so down.
I think you can carry on, Dr. Sesma. We can see the slide nicely.
You can see, but I can't.
Yeah.
That's
okay.
Let me see. I'm trying to see because I lost the presentation. Sorry about that. Let me see. Just hold on.
Would you like to stop share and share again?
Let me, yes, just hold on. I think that I move it here in the view. Sorry about that. Gallery.
What do you see on your screen, sir?
Show me the times, yeah, full screen. But I'm now just watching you. I cannot see I cannot see the, let me see now.
So I just stop sharing and you can share again. Is that good?
Let me try.
Right. I'm stopping now.
Let me go back. I'm sorry for this unfortunately issue.
No problem. We still have 6 minutes of your time.
Now, let me see. Okay, let me see if I can share now. I think I saw it. Okay, can you see now the screen? Sorry about that. So going fast because of this, when we go zoom in the situations, you can see the parameters that we're seeing here, like a horizontal corneal diameter, how was reduced, the intraocular pressure, how was controlled. You can see at the onset and at the end, you can see how the cupping was not affected, which is important. The actual length, how the tendons was reduced, specifically when we do procedures under 1 year of age, this is important. Also how, when we control the IOP, how the corneal thickness was reduced, also the refraction. So we have these results, we have stability, and we control the IOP. So the issues that we have continuous follow-up of this patient every 1 or 2 months to check that everything was going good. And the implication of this one is that we need to be careful. I'm not saying with this one that we need to use the pressure flow in these cases, but based in the classical treatment is not a good option. This could be open a door, and that's my intention to bring this case today, is open the door for further research, randomized prospective, to evaluate if this one can be a door that we are opening. It's like a light at the end of the tunnel. So in conclusion, it's an option. We need to use it in caution with children, and further research are needed. And that's why I brought it to you guys, the expert in the field in the world, as a humble pediatric ophthalmologist. Thank you very much.
Thank you. Thank you, Dr. Gorka. And that's indeed another indication for MIGS in these very challenging conditions. If I could get Dr. Carsten in. Dr. Carsten, are you there? Yeah. So,
good morning. Yes.
Good morning. Hello. Thank you for joining. I would just ask you to broadly define how you would choose a MIGS with all the array there. When would you choose an angle-based, a stripping, and an outflow-based? In a nutshell, if you could just tell us that.
Yeah. I think that is the most challenging issue in MIGS today, because we have a lot of different devices, different approaches. And the hardest thing is to find the right procedure for the right patient. So I'm really astonished about the wide spectrum you using MIGS. So in my private setup, it's completely different. Well, it is different. I'm choosing mostly MIGS in combination with cataract surgery, and the vast majority of my patient population are open-angle glaucoma, and about 30% of pseudo-exfoliation glaucoma. And we have heard about the different approaches of MIGS. So cutting procedure, and I'm absolutely agree with the speakers before, working better in younger patients, working better and more predictable in patients where the trabecular meshwork alone is affected. They work better in younger patients because there is more elasticity and their more retraction, and the long-term results are much better. So a stenting procedure are for my perspective, very good in patient with coexisting glaucoma, but mostly join us for cataract surgery. So to reduce medication, not to reduce the pressure so much, but to reduce medication. And so the dilating procedures, canaloplasty of different, with different devices is good. We've seen this before, and we achieve now comparable results to external approach, so we can use it also in younger patients as well. Yeah, but you're absolutely right. The most challenging thing is to get the right patient.
Thank you. Dr. Ganesh, I would just, if you could come in, how would you decide a canaloplasty versus a GAT? For instance, in the patients which you did a canaloplasty, why would you not do a GAT procedure? And then,
yeah, so my take on that is, if it's a rapidly progressing, condition, so you see the patient every visit and the intraocular pressure doesn't seem to come down, and you keep adding medications. So I feel that the Schlemm's canal will not be intact when I would go and approach. And invariably, you will be using some medications which increase the uvascular outflow. Now, these are all conventional procedures which work on the conventional outflow channel. So if you direct the aqueous humor through a different mechanism, then these procedures may not work. So in our situation, we sort of switch off medications which increase the uvascular outflow for some time, manage them on oral CAIs, and then proceed with a MIGS procedure or with a canaloplasty or a deep sclerectomy, so that the trabecular meshwork is sort of filled with, the fluid. It's a more non-collapsed, and it functions better, especially when you open it from the outside. If you were to do a deep sclerectomy in eyes which have uveitis, you'll find that until you remove the juxtacanacular tissue, the flow is very restricted. The moment you remove it, there's excessive flow. That's something nice to see that. So you have to make these tweaks before you plan for your MIGS procedure.
so in India, what is the device that you use for your canaloplasty? What is available?
Canaloplasty is the same as the GAT suture. It's a 5-0 or a 6-0 proline suture. And since we have that, we started using that with you put in a 9-0 proline suture in C2 and tighten the Schramm's canal.
All right. Okay. Dr. Tanuj, your take on that? Would you be doing canaloplasty for any cohort of patients?
No, Shrifata, I have not done a canaloplasty, and with the suture one, I have no experience. We just do visco dilatation of the canal, but we don't suture it with the proline. So I can't comment on this.
Okay. Anybody, any of the panelists, Sunita, Siddharth? Because I think this is one procedure which is relatively less commonly done, at least in India. We haven't seen too much of that. So would you have a specific condition or would you do it anytime, Dr. Pandav?
I think so, because I think we are comfortable with other procedures and they work very well.
Oh,
So I haven't tried.
yeah. Right. If we could now go on to what could go wrong, and Dr. Shamira is going to show us his confessions on complications. Dr. Shamira, over to you.
Thank you very much for inviting me to speak. It's a real pleasure. So I've been in practice now as a consultant for 16 years plus, and I've seen every complication in the book and some of them that aren't in it. So this is going to be a video to show you what I've learned along the way. So sit back and strap in.
Trabecular meshwork minimally invasive glaucoma surgery, or MIGS, has been the latest buzzword in glaucoma surgery. These innovative procedures have revolutionized the management of glaucoma, offering patients safer and less invasive options compared to traditional surgeries. However, as with any medical advancement, MIGS is not without its challenges. In this presentation, we will explore the potential complications associated with MIGS, providing a comprehensive overview to better understand the risks and how they can be managed. Here are my financial disclosures. MIGS share many similarities and are often more effective when combined with phacoemulsification. These devices are commonly marketed to both cataract and glaucoma surgeons. While a primary challenge is that scarring and failure in the trabecular meshwork cannot be modified, there are notable advantages. MIGS do not cause hypotony as they are limited by episcleral venous pressure. They also do not compromise the success of future trabeculectomy and boast a significantly better safety profile compared to any open surgery or MIGS that drain into other areas. The complication rates for these devices are generally low, especially with the iStent and Hydrus. However, complications can still occur. I will provide a brief overview of some of the more significant complications I've encountered, along with strategies for managing and preventing these in the future. Here we have a Descemet's membrane detachment caused during a Hydrus implant insertion. It is a rare complication in MIGS. Of 25 eyes analyzed by Kazarunian et al., there was only one case of peripheral Descemet's membrane detachment. Similarly, Hillman et al. Reported 2 cases out of 54 eyes studied. A strategic approach to managing Descemet's detachment is to introduce an air bubble into the anterior chamber. This technique utilizes surface tension to gently maneuver the membrane back into place. Care must be taken to ensure the air bubble is approximately half its final size to minimize the risk of IOP spikes while monitoring for potential blood accumulation. Peripheral anterior sine K formation is a recognized complication following MIGS. Its occurrence at the inlet rather than the 3 windows indicates a more pronounced role of the inlet in drainage. PAS is notably more prevalent in angle closure amongst MIGS procedures. Rao et al. Studied the PAS and scarring after microincision trabeculectomy and GATT using ASOCT. They reported that severe scarring was seen in more than 65% of GATT eyes compared to only 31% of MIT eyes, and that the trench pattern of scarring seemed to predict the need for medications for IOP control. Moreover, postoperative PAS in 1 to 2 quadrants in the nasal incised region was seen in 12 MIT eyes and 16 eyes with GATT, while PAS in more than 2 quadrants was seen only in 6 eyes after GATT. PAS formation, of course, can also reduce efficacy, particularly following GATT. Endothelial cell loss is another complication in MIGS. Following the landmark COMPASS XD study, the CyPass microstent was withdrawn from the market due to significant ECL, endothelial cell loss, compared to the cataract surgery group. Conversely, there was no significant differences in ECL between the phaco eye stent and phacohydrous implants and their cataract surgery-only control groups. According to Ahmed et al., mean percentage decrease in ECL at 60 months was 14.3%, plus minus 13.4% in the eye stent inject group, and 14.8% plus minus 10.3% in the cataract surgery alone group. Similarly, according to Fia et al., hydrous implantation showed changes in endothelial parameters comparable to those seen with cataract surgery alone. The higher ECL absorbed with CyPass microstent compared to eye stent and hydrous implants can be attributed to their anatomical positioning within the eye's angle. The CyPass microstent, located in the supraciliary space, follows the curvature of the inner sclera, placing it closer to the peripheral cornea. This vertical orientation increases the risk of contact with the corneal endothelium, potentially causing mechanical trauma and therefore higher ECL. In contrast, eye stent and hydrous implants are inserted within the Schlemm's canal, with the eye stent's short nozzle protruding further from the endothelium, and the hydrous microstent lies parallel to the iris, continuing into the canal. These positions keep them further from the cornea, reducing the risk of endothelial damage and contributing to lower ECL compared to the CyPass microstent. Another potential complication in MIGS is implant dislodgement. For instance, in a video, a hydrous implant is seen diving down, a situation commonly encountered by surgeons. If the implant fails to stay in its intended position, it can cause discomfort and functional issues such as eye overpressurization or canal compression. Repositioning or removal may be necessary to prevent further complications from the dislodgement. Repositioning involves carefully grasping and reinserting the hydrous to ensure it functions properly and remains correctly positioned within the canal. Iridodialysis is a rare but significant complication that can occur during MIGS procedures. It involves the detachment of the iris from its root at the ciliary body, resulting in abnormal iris positioning, irregular pupil shape, changes in iris dynamics, and potential visual disturbances. In the Horizon study, which compared cataract surgery with the implantation of a Schlemm canal microstent versus cataract surgery alone, one case of iridodialysis was reported among 369 eyes after hydrous implantation. This complication can be challenging to manage, as demonstrated in this video, where iridodialysis occurred during the placement of a hydrous implant following a particularly difficult phacoemulsification. The patient's significant movement during surgery contributed to approximately 40% iris detachment, albeit with minimal bleeding. To address this complication, 2 Huffman pockets were created and 10 zero-proline sutures were carefully used to reattach the iris. Postoperatively, the iris achieved a near normal appearance, highlighting the successful management of this challenging scenario. Transitioning to complications associated with eye stents, achieving precise placement of eye stents is crucial for efficacy. Initial insertions may induce apprehension, but proper technique ensures accurate placement and function. During training, assisting with gonial lens placement can enhance confidence. Care must be taken during subsequent insertions to prevent corneal striae and injector tilt, which can hinder correct delivery. Instances of over-insertion or bias can compromise device performance, requiring careful adjustment for optimal positioning within the trabecular meshwork to ensure effective drainage. Improper placement may lead to dislodgement, necessitating repositioning using a blade or the injector, with options for intraocular or extracorporeal reloading. In this context, intraocular reloading was employed. Caution is advised with eye stent inject due to the limited four-shot capacity per procedure, emphasizing the need for judicious use. The GTW model's larger flange helps mitigate risks of over-insertion, while the eye stent infinite allows unlimited reloading attempts, facilitating optimal repositioning with headshot limits. A phenomenon known as pinball visit occurs when an improperly inserted eye stent detaches and moves within the eye. This requires precise retrieval under gonioscopic guidance using Kawai forceps, followed by rethreading and reinsertion to restore proper function. In another case, an eye stent became lodged behind the IOL. It was carefully rethreaded and reinserted into the correct position. When dealing with superficial insertions, a trocar can be utilized to stabilize the stent into a more secure position. Care should be taken to avoid placing irrigation aspiration tools too close to the eye stents to prevent displacement or disruption. Hyphema is a common occurrence in TM-MIGS procedures with wide variability in its incidence across studies. For example, Seek et al. Found that 17% of the eyes experienced transient hyphema in their study, comparing standalone KDB and combined KDB with cataract surgery. In another study by Fillini et al., hyphema was identified as the most common complication, with incidences of 3% in the KDB group and 14% in the trabectome group. Fortunately, hyphema is typically self-limiting without significant clinical implications. However, larger hyphemas may require evacuation, especially if there's an associated risk of elevated IOP or corneal staining. Trabectome procedures may lead to more frequent hemorrhage and long-term intermittent hyphema due to their larger drainage area. The iridodialysis observed here was caused by the KDB procedure, emphasizing the necessity of maintaining a clear surgical field. This condition can result from applying excessive downward force during the procedure, while excessive upward force may lead to descemet membrane detachment. However, such complications typically do not require repair unless they are severe. In conclusion, although complications are a natural part of learning TM-MIGS, efficient management skills are essential for handling various devices. Ensuring thorough patient education and adhering to best practices without taking shortcuts are key to achieving optimal outcomes. Setting realistic expectations and striving to exceed them is crucial to patient satisfaction.
Thank you, Dr. Shamira. That was a wonderful overview of a rather confessional video of what all can go wrong. So I'll just take this further to you quickly, that now that you've been in the business for so long and have gone through the gamut, what would be your take on which MIGS to avoid in which patients? I mean, which would you say that this patient, I would not do this and I would do that? Would there be an assessment of?
So I think, I mean, overall, I agree with what was said earlier on. I think that was a great talk earlier on about talking about the key cases to avoid. Personally, I don't think that angle closure is a contraindication. We have plenty of cases where the angles opened up after cataract surgery, that it works very well. I think in terms of picking your patients, that's probably the most crucial thing that we can do. And I think things will open up later on when we have more information about how the trabecular meshwork flow occurs and the collector channel. So I think the next great vanguard is in imaging of that area. And that will tell us a lot more about which patients to choose. At present, I would say, if in doubt, stay cautious. Don't go for anything that can potentially cause any problems. And I think the good thing is that at least that we have plenty of opportunities now.
Right. Thank you. Well, we're really running out of time, and I think we'll come on to the cases section, and we'd see we have 4 interesting cases, and we'd ask Dr. Yap Zhu Li to come in with her case of hydrus tearing through the Schrems canal. And that's quite an oops, I think. Yeah, if you could share your screen, please.
Hi, can you hear me?
Yes, we can.
Okay, wonderful. Hi, I'm Zuli. So thanks for letting me speak. Is this on full screen? Is it on the full screen?
Not yet. Could
Oh,
you
it is.
put it full screen, please? Yeah, that's
Yeah. Okay, hi, thanks for having me speak today. Great talk so far. These are my financial disclosures. And I just wanted to present this video, which is of a high myope. It's an edited video, of course, but it's not been sped up. And it appears here that the stent is inserted fairly smoothly, no resistance. And of course, I always check to ensure that all 3 windows are seen after insertion. So just, again, this is in real time, not being sped up. It's a little bit blurry. So you go in, slide it in a little bit better and have a look. And to my surprise, I can see that the metal is glinting happily away in the anterior chamber. And I can see that the stent is actually torn through and 2 windows are sitting in the anterior chamber. So torn through the Schlemm's and the TM. And in these cases, you do have to remove it and replace it. So ensure that the tracking wheel has been rolled all the way out, or you are going to have trouble trying to re-grasp it, as you can see over here. So make sure that the tracking wheel is rolled all the way out and that the deployer is in the correct position to re-grasp the stent, and make sure that the tip of the injector is all the way behind your stent before you can then roll it back out. While doing this, keep the injector pressed gently against the back wall so that you don't have any forward movement. Otherwise, you're going to cause, I'll just replay that again right at the end. If you don't do that properly and you pull too much forward, you could induce a goniotomy, which, you know, will probably lower the intraocular pressure, but really wasn't the procedure that you were going for in this case. And then you don't want to reinsert it in the same position. I don't have a good video of reinserting it, so I'll go to the next one. Here is another example. Again, the stent goes in very smoothly, no issues here, or so I think. And I don't suspect anything. However, when I'm checking for the placement, so there again, slide it in, check the placement, and I'm like, oh, it's very shiny. There doesn't seem to be any membrane dulling the metallic sheen of the implant. If you look very carefully, you can see the implant's actually sitting anterior to the trabecular meshwork and on the iris. I need to convince myself again. So I go in and I can actually touch the implant with the Sinski hook over there. And I can sort of pull it and you can feel metal on metal. So there you go. You've got to explant that again. And again, always ensure that the injector is posterior enough to the implant to be able to re-grasp it. And because this occurred very early, where it was tearing out, you can see when you insert it, you can go just past the point where it tore out. And this time you can see that there is a membrane, okay? It's not so shiny. You can actually see that there's a membrane and it's sitting within the Schlemm's canal, not in the anterior chamber. Now, in both these cases, they were very high myopes and it was done at the end of the cataract surgery. So, you know, you can do it at both times. You can do it either at the start of your surgery before you do the cataract surgery, or you can do it after. And in these elongated eyes, they're structurally a little bit different. And often if you do it at after the phacoemulsification, you use a lot of excessive viscoelastic in order to achieve your desired intraocular pressure. So there's easier collapse of the inner wall of the Schlemm's canal. So one of the pointers is to perform the incision prior to the phacoemulsification. Yeah, that's my main tip really, and that you don't want to leave it in the anterior chamber, obviously, and so you always want to re-grasp. And if you see that the area has torn out, you might have to go past the area where it's torn, or you just have to go to a completely different area. So in the first video, I couldn't use the nasal area anymore because there's a large area that had torn out. So I had to switch and insert it inferiorly. Yeah, so just 2 quick videos just to illustrate that.
Thank you. That was really scary to look at. And since the Hydros hasn't been introduced in India, I'll put it back to Dr. Shamira. What is your experience of endothelial cell loss with this? Because this was quite a large implant compared to the other MIGS.
Right. So in terms of comparing to the sidepass, it's far less, but it's probably more than the iStent. And actually what they've shown in a 5-year Horizon study, which was a well-conducted study, showed that probably most of the damage occurred initially. And this was due to the insertion of the device. It's a large device, people have multiple goes at doing it. However, in terms of when you look at it over the many years of follow-up, the endothelial loss is quite stable, in contrast to the sidepass, which got worse over time. So I think it's actually quite safe to use. The FDA would have pulled it if it caused any problems. And remember that 30% endothelial cell loss, which is the marker for the endpoint here, is not a PROMS marker. A PROMS marker will be something like needing a endothelial graft. So actually, it's quite safe.
Right. Thank you. Dr. Swati, you'll come on next with GAT, not a straightforward journey. Yeah, thanks.
I hope my slides are visible. So, yeah, okay. Thank you, Saiban.
Yes.
Thank you, ma'am, for inviting me and for giving me this opportunity. And thank you, AIOC and Saiban, for being such a good host. And yeah, so I'm not sharing my screen. Oh. So I hope it's visible now.
Yes.
Ma'am. Yes. So I just want to discuss 2 cases where I thought I did the best for the patient, but then it is going good, but it was not so straightforward. So GAT involves threading of a catheter or a suture 360 degrees through the Schlemm's canal and opening, creating a trabeculotomy. And it allows aqueous humor to flow from the anterior chamber into the Schlemm's canal. And as shown in Dr. Shamira's presentation, hypotony is not there because it is limited by the episcleral venous pressure. So our patient is a 34 years old male patient who was referred from outside as juvenile open angle glaucoma, who was already on 3 medications, dorzolamide, timolol, and travoprost in both the eyes. And he gave history that his father also had glaucoma. So at presentation, he showed all the signs of classical signs of juvenile open angle glaucoma with pigments on endothelium and a 0.9 CDR, but he also had cortical cataract in both the eyes at the age of 34. This is the fundus optic nerve head picture where they're showing there's hardly very thin rim remaining in both the eyes. He had thin corneas, 486 and 494 in eyes respectively, with a refraction of -3 in both eyes and open angles. This was his visual fields, and the right eye was worse than the left eye. So, and his axial length was 26.18 in the right eye and 26.16 in the left eye. So we thought of doing, okay, fine, what should we do? And also we got a retinal evaluation done. Retina also had multiple lattices with holes, and both eye barrage laser was done. And the patient was on 3 medications. In July, when the patient came 3 weeks after the first visit, he was continuing on AGM, and right eye tenito hook plus MIGS was advised. So I did his tenito hook goniotomy with phaco in the right eye, and POD1, the pressure was 6, vision was 6.6. And the right eye AGM was stopped, but the left eye was still continuing on 3 AGMs. POD8, the patient came with defective vision since one day. His vision dropped from 6.6 to 1/60, and he had hyphema, and also he had vitreous hemorrhage. And the surgery was uneventful. So I was wondering why this happened. But okay, on conservative management, his vitreous hemorrhage slowly resolved. IOP was well controlled, and when he came on POD 60, that means 2 months from the first surgery, his IOP was 80. Considering that his optic nerve was 0.9 cupping, so I thought better to keep him on 1 medication. From 3, it came down to 1. And then I thought, because again the right eye is the pressure is building up, let me do a more invasive procedure. With my fingers crossed, I advised suture GAT with cataract surgery in the left eye. And I had explained everything to the patient that already this eye has happened, so there are chances of hyphema to be there in the left eye as well. Fine. So I did a suture GAT with phaco. On table, there was a little bit of vitreous wick coming from 7 o'clock position. And then I had to do a limited anterior vitrectomy. Vitreous went back and everything was fine. But there was severe bleeding intraoperatively from the Schlemm's canal. So I waited for air, for bleeding to stop, put air tamponade, waited for 5 minutes, did another surgery of the patient, then again came back to this patient, cleared of the blood, and left OVD this time. On POD1, there was air bubble also in the AC. High fever was there inferiorly and temporally, and I started vitamin C as is our protocol. Pressure was 10 in the left eye, and the vision was 6/6. So I was happy. But then on POD9, the patient came. He had microhyphema. He had 32 pressures in the left eye. He came with pain. He started bidin LS or the brimonidine. So left eye was also on again 1 AGM, right eye also on 1 AGM. On POD10, patient came in emergency department with the pressure of 54, and this is a picture. And he had epithelial edema, blood clot at 4 and 6 o'clock position, in fact, diffuse microhyphema throughout. And immediately we had to start combination, and we had to give 50 ml IV mannitol also. Then I waited, vision dropped down to hand movements, and then I had to take, I did AC decompression for him because pressure was 54, and then that day when he came, it was 60 plus. So I had to do an AC decompression, and then pressure came down to 37, but then I decided next day I should do an AC wash. So I did AC wash, and still pressure after AC wash also was high. So again, patient was on 3 medications on the left eye, one right eye doing good with 1 AGM. Then on POD 19 and 20, again, the pressure was 53 and AC decompression was again done. And post ACD, it was 9. B scan showed vitreous hemorrhage. And this vitreous hemorrhage was not resolving no matter what, head positioning and everything. So we decided that we will do a PPV for the patient. So we did a PPV for the patient, but my retina colleague could not see the base properly because of the epithelial edema. So as much as vitreous she could clear in the center, she cleared it up. And Ripatec was added. So 4th AGM was added again in the left eye. So then, because the pressures were 40s, 50s, and it was like POD 50, so the patient underwent RD implantation. And now, when the patient came for the last follow-up, again, the patient is on 4 AGMs. So I'm waiting for bleb to form, and then I should remove the supramed suture, and then the pressures should stabilize. So this is the whole story. This is the last picture which I took after RD implantation. Eye is quiet, tube is fine, everything is good, but the pressures are still high. So why GAT? Because he's a young patient, advanced glaucoma, chances of macular snuff out with trab, and I wanted to preserve the conjunctiva for future for tube or trab, and actually he needed a tube, and because it's a high myop with barrage laser for the lattice hole. So this was my go. Fine. Next patient is a 12 years old male child who is also a juvenile glaucoma. His parents live in Germany. He came to Germany from Germany to India just for a checkup, and then to there
you'll have to wind up fast.
Yeah.
We have 2 more cases later. Yeah.
So he had thick corneas, but high myopia, and he also underwent barrage laser in both the eyes. Then I did his better eye first GAT, and followed by the second eye. To my surprise, again, the first eye which I did GAT was doing better, and the second eye again developed steroid response, and then we had to again add medications, and he also bled a lot. But this is the final. So this is the POD1 right eye, and this is the POD 3 months of the left eye. So as of now, patient is fine. Patient is having an IOP of 12 and 10. Visual acuity of 6/24 in the left eye. On 3 AGM, right eye is on 3 AGM, which is the second eye which I operated. The first eye is on 1 medication. So this again, why GAD? Same reasons. So my observation is that steroid response occurs earlier than usual in these patients. Why? I don't know. IOP lowering is less in the fellow eye, as my colleague Dr. Ganesh also has said this, and bleeding in the second eye is worse than the first eye. So why? So I asked the panel to help me out that why this happens. Thank you so much.
Thank you. What a nightmare, Swati, and hats off to you for sticking by, because we don't. So I'll open this up to Dr. Carsten. With your stripping procedures, have you seen these much of bleeding? Especially both were high myopes, and I'll take that on to
The risk of bleeding, if we open up the trabecular meshwork and if we do it over 360 degrees, yes, of course, for obvious reason, the risk is higher. So what was in this particular case, I was wondering about the steroid response, because we know steroid response depends on the malfunction of the trabecular meshwork. If you open it up or remove it particularly, then the risk should be lower. My impression, I'm not very experienced with gut with the suture. If I'm doing a gut procedure, I mostly prefer to use an eye track. So the advantage of the eye track is that you have visual control, and you are absolutely sure that you stay within Schlemm's canal, and then you have a real 360 degrees opening. I have using other devices like the Omni and the Suture as well. And in my hand, I sometimes observe that I'm not anymore in Schlem's canal. You go around, you reintroduce it sometimes, but sometimes you're not able to open 360. And that might cause a pressure spike, a faster scarring, or a steroid response. But very interesting cases, really tough ones.
So quickly, Dr. Siddharth and Dr. Sunita, your take on, you think the high myopia and the laser, which was a common factor in both, had anything? You think they'd be more elastic and tend to bleed? What would be your take on that?
I don't think the high myopia played a role. Probably the younger age might be a common factor, but it's really you cannot predict the extent of hyphema when you do a GAT. It's very difficult to predict it, except if you have a very definite risk factor like blood thinners. Otherwise, it's very difficult to predict.
Sunita, quick, and then we'll.
Yeah. Actually, in high myopes, I feel the risk, apart from bleeding, the risk of hypotony is also too high. So I don't do GAT, and if it's very advanced juvenile open angle glaucoma, then I think TRAB would be better, although the mitomycin C can also cause hypotony. So I do a limited, excision of the trabecular meshwork, maybe I think KDB or so, rather than doing GAT. But yes, I think young patients with high myopia are more at risk of bleeding. That is seen.
Well, I think we'll just have to move on because we have very little time left. So Dr. Judy will come on with her case of bubbling under pressure. Could you share your slides, please? Yeah, thanks.
Yes. Is it sharing? Can you see?
Not yet.
Sorry. I don't know why it's not sharing.
There's a green share button. If you could.
Yeah, I have clicked on that, but it doesn't seem to want to share. Now, let me just turn that. Apologies.
You'll need to open up your presentation first, Dr. Judy, and keep it in your background desktop.
Yeah, I do have it on my desktop, but for some reason it's not wanting to share.
Do you have the share option on the Zoom window?
Yes, it says share, allow Zoom Workplace to share your screen.
You are on Mac, right?
Yes.
You have to go to privacy settings and allow Zoom to record screen. Security and
My
privacy.
apologies. Do you want to move on to the next speaker and I'll try and fix this so I don't want to delay everybody?
I think we'll do
Yes.
that.
Yes.
Dr. Sushma, if you could share yours, please. Meanwhile, we'll have this one.
Is my screen visible?
Yes.
Well, thank you for the opportunity, and I'm just going to quickly run through the case in interest of time. So we had a so we had a 65-year-old hypertensive lady who was a known case of glaucoma and currently using bimatoprost, had history of decreased vision recently since last few months, and was really bothered about the periocular pigmentation. Anybody would, if you look at the kind of disfiguration she had. Well, the visual acuity was 612 parts and 69 parts with the best correction. The IOP was 17 and 16. Pachymetry being low in both the eyes. There was some significant cataract in both the eyes, and gonioscopy showed open angles. This is how the discs look like. Both the eyes, large discs, 0.8, and inferior temporal thinning in the left eye. And so clinically looked like a primary open angle glaucoma with cataract in both the eyes. And this is how the visual fields looked like, 24-2 and the 10-2. So as you could see, the left eye was more affected than the right. And this is how the OCT looked like along with the macular GCC. So we definitely reached to a clinical diagnosis of primary open angle glaucoma with cataract in both the eyes, and planned for phacoemulsification with the EDOF lenses, with the toric correction, and with eye stent inject for the right eye, followed by left eye, by right eye, because the cataract was more in the right eye. And meanwhile, I shifted to beta blockers because the periocular pigmentation was significant. So this was an uneventful surgery. After putting a intraocular lens in the bag, we did the eye stent inject implantation. As you can see, the first eye stent being implanted and the second eye stent being implanted. So there was nothing peculiar about the surgery as such. So post-operatively, also the patient did very well. The visual acuity was fine. Both the stents were seen in the nasal angle on the second post-op day. If you can see, the only thing was there was a blood clot over the upper eye stent, as you can see, and the lower one was fine. However, after 4 or 5 days, it the sort of cleared, and we were pretty happy with the routine post-op treatment. Well, when patient presented after 3 weeks for a regular check, the pressures were going little higher. As early it was 10 and 12 and now 15. And when I did the gonioscopy in the nasal angle, if you can see here, there was iris coming to over the upper eye stent, and the lower one was almost completely occluded by the iris, which was quite surprising for me because there was no extra inflammation or anything. So I decided to start on pilocarpine, assuming that may sort of pull the iris back. However, that did not work for me. Up to 1 week we observed, and after 1 week when the patient came back, it was exactly the same. So I decided to take her in the OT and did the pass release under topical. So was worried about the dislodgement and all while removing, but it was a smooth sailing. I just had to retract the iris a bit with a blunt instrument as soon as I saw the angle, and that was pretty okay. And this removed the heel-on from the chamber, and the patient did well. The pressures also came back to 11, 12, and there were no PAS. So that was subsequent follow-ups also, patient did fine. So that was a learning, but I was worried about now the other eye. So when I did the other eye, that was almost 6 months later. I thought, what could I do to prevent that? So in the beginning itself, I started pilocarpine, although I never used pilocarpine otherwise for my eye stent cases. So yes, but the other eye did not develop a synechiae. And this is the picture post-op. For both eyes, after a year, the pressures were fine, vision was fine, and both the stents were okay. This is the face picture. You can see how much the difference it created by removing the drugs. And both the eyes were standing clear of PAS. So this made me look through that how commonly we do see PAS in eye stent. So there was a variable incidence reported. If you look at the meta-analysis, it was considered as 7.4% in a large cohort of 1,000 eyes. However, certain studies reported none in like 125 eyes or 400 patients, whereas certain smaller studies had 4 out of 28, 2 out of 53. So I was wondering why there is so much of variability. Is there a technique, or is that a patient? Then looking at the causes of eye stent blockage, well, there can be overimplantation, malpositioning, or the bleeding from the stent. But in our case, the stent which had blood clot covered was actually better than the other one. And then these PAS come from nowhere and block the eye stents. Well, the meta-analysis also showed that 1/3 of the stent blockage was happening due to PAS in almost 7% patients, as I mentioned. So what do we do to manage them? Well, there is some role of medical management. However, there's a controversy whether we should use pilocarpine or hometropine to reduce the inflammation or pull the iris back. There are studies where they have used YAG laser to open up the eye stent or make it patent if the iris is plugging them. The surgical separation, as I demonstrated, has also been done earlier. And there are certain reports where they have not done anything and the still patients have done well. So I guess with this case, I can just say that there are newer challenges with new devices that are bound to occur. We just have to be watchful and carefully observe to save the failure. Prevention and minimal intervention is definitely the key to success, and best is to use whatever is the available evidence and the clinical wisdom to take care of these issues. Well, thank you for your kind attention. That was the.
Thank you. Thank you, Sushma. I think that was very well presented and rare complication, but very well discussed too. Dr. Judy, if you're ready, I think we should take your case now. Yeah, okay. If you could share your screen.
I can now see. Can you see my screen too? Yeah, great.
Yes.
Okay, well, thank you so much for the invitation. I see that most of you have much more challenging cases in other parts of the world. So today I would like to share with you a case that hopefully address some of the differences that we have. So this is the 80-year-old Caucasian lady with normal tension glaucoma who's referred on to me for surgery. She was under care of another ophthalmologist, and she was diagnosed in 2012 with intraocular pressures around 20. She was treated throughout this time with latanoprost. However, in 2018, she switched over to a combination medication, and her intraocular pressures dropped to 10 to 14 millimeters of mercury. And then she was referred on to me as a vision drop, and the cataract has developed and her glaucoma has progressed further. She's otherwise a well lady. This is a visual field test. You can see that she is worse in the left eye compared to right eye, but that she's still in that sort of early to moderate category. Her OCT probably looks a lot worse than her field tests. And this is just to share with you of her case. So we have completed the phaco with intraocular lens insertion. Just to show you what the setup that we have in clinics, as theaters, and view is very important, as previous speakers have alluded to. We have the iStent Infinite, who just came out in Australia, and I try to space them out as much as I can. So with the first two placements, I usually come out, refill the AC, and then reposition my microscope before I put the third stent, so I can extend that as wide as I can. During the process of removing viscoelastics, you can see this blunting of vessels, which shows that the stent's working quite well. So the final was to hydrate the wound and close up. However, at this point in time, I noticed there's a curve in the cornea, which looked a bit unusual, so I went back in. As you can see with the IA, there's some folds in the Descemet's membrane. So at this point, I injected air to assess the Descemet's membrane, and confirmed there was a large detachment that also involved the center part of the cornea. I had to pause and think and use a bit of my corneal training at this point. So I drained out the fluid in the interface by carefully placing an incision away from the visual axis, obviously, and avoid penetrating Descemet's membrane, and slowly drain out the fluid out of the interface. And this section was very much shortened. It took at least another 20 minutes to really drain the fluid out, and really try to use the bubble to be on my side and continue to drain the fluid out of the interface. It's important to use a blunt forceps to open the wound. As you can see here, the bubble expands as that gets removed. So once I was happy that Descemet has reattached, I refilled the anterior chamber with full air. And you can see that in contrast to DSEC and DMEC, her eyes are actually really soft, and that's because of the presence of the iStent injects. After waiting for 10 minutes, I was very mindful of her pressure because she is a glaucoma patient. I released some of the air from the anterior chamber and applying some of the corneal techniques of stroking the corneal surface to try and drain that out as much as I can from the wound. And you can see after another 5 minutes of stroking, her cornea is cleared up better than before. I put a backup incision inferiorly just in case that there's further drainage that needs to be done on the slit lamp on day one, and hence I placed that inferiorly. So surprisingly, on day one, her vision was actually 6/9 or 20/30. Her pressure at this point was 10 millimeters mercury. Immediately post-op, it did go up to about 30, which I released some of the air bubbles. It came down to about 8 when I left her from the operating room. And her cornea appears to be clearing quite well, and the Decimate's reattaching. At 2 weeks post-op, she was achieving 20/20, and surprisingly, her pressure actually came down to 8 millimeters mercury without any glaucoma drops, and she continued to use steroids at this point in time, antibiotics. At 6 weeks post-op, surprisingly, the left eye actually did better than the right eye, and her intraocular pressure came down to 6 millimeters mercury with no medications, and her Decimates was well attached. So I guess this was, for me, quite a learning point, because we often do see Decimate's membrane detachment post-cataract surgery. It was reported about 45% post-cataract surgery, more common in ECI than post-phaco, but other surgeries have also been reported, such as trabeculectomy, glaucoma drainage tubes, vitrectomy, and canelostomy. There are other risk factors for spontaneous detachment or early detachment, such as genetically weakened adhesions, or possibly shallow anterior chambers in some of the peripheral anterior nuclei. Tight incisions or blunt blades that are used to make the incision, and also inadvertent insertion of instruments between the stroma and Decimate's membrane. Older age and dense cataracts are also predisposing factors, and as Shamira had mentioned earlier, some of the MIGS, such as hydrous, probably are the ones I see more commonly, but that's rather than incision, it was actually further in. And I wondered, with the iStent Infinite now, with the 3 stents, I probably manipulate the wounds a bit more than I usually would, because I will place 2, space them further apart, and I'll come out and reinsert. And I wonder if that's actually contributed to this particular case. So it's important to identify these signs early, as if you don't and they have late treatment, it can have consequences. So intraoperatively, sometimes you can see the tears at the paracentesis or the wound itself, or in this case, the unusual crescent line in the cornea. And postoperatively, they could present as persistent bullous corneal edema, more than 2 weeks, or hazy corneas, or even bulging of the Decimate's membrane in the anterior chamber. So as I mentioned, if you do not reattach the Decimate's membrane early on, it can cause permanent wrinkling and fibrosis and shrinkage, and that can cause poor outcome. And unfortunately, there's no gold standards for such cases. So small tears are probably relatively common and can be managed medically. However, if they have a large tear, such as this case, if you can identify intraoperatively and manage it on the table, will probably be the best place to do it. If it's identified postoperatively, then start topical therapy and plan to take them back to theatre and perform decimoplexy or suturing of the Decimate's membrane. But the key point in this case, I think, is that Temponar is relatively difficult in glaucoma patients. And during my corneal training, we do a lot of, D6 and DMEX, and we actually place the pressures quite high because that's what allows Decimate's membrane to reattach. However, in these cases, because you have these MIGS in place, the pressure will be quite low. So there's a fine balance there. You want that to reattach, but you're also going to be mindful of the optic neuropathy. So that was just a case there to share with everyone, and hopefully I can get some feedback there. Thank you.
Thank you, Judy. That was a lovely case and really nicely managed. We glaucoma surgeons at least rarely tend to go into the cornea and take out the fluid like you did, but that's a tip that at least I'm going to take back home. I think we're almost at the end, and rather than a summary and conclusion of this is really that it's difficult to choose which patients to do which MIGS in. The best would be an early open angle glaucoma, but as we've learned, the indications are expanding, and we have now, especially in the Asia Pacific region, we've also seen that angle closure does not need to be a no, and early secondary open angle glaucomas also seem to work well. And with that, I now pass over the session to Dr. Satyan, who's the president of the GSI, for his closing remarks. Dr. Satyan, if you could come in, please.
Thank you, Sushmita. At least finally you could call me for some comments. Thank you. Thanks, AWS, and thanks to Dr. Santosh. I would just look at the MIGS as into two components. One is for the early beginners, and also for the already whoever is doing a lot of complicated procedures. Once we know that we are the beginner, then it is better we have some guided procedure done, like make sure that we have the open angle glaucomas and you begin with the very, like a bang or something like that to start with, and then we can go on to do all that other procedures. That is what the suggestion can be for the beginners. And once you have learned the procedure, you try to see your patients post-operatively, what are the possible complications that you are getting or how it is responding. Especially when you are having your anterior segment OCT, you can just see that how you have done the procedure. So that really helps you out. The next thing is, once you have learned your procedure, then you can look at what procedure to be done for which patient you can look at, and then you can go on doing that. So the mix is going to be there. Only thing is we need to kind of keep modifying our procedure and also keep on refining and understand how things are happening. So that would be the advice for the whoever is doing the mix. But it is going to stay, and we need to see how good is going to be the long-term outcomes. Possibly now we have at least close to 5 years of the outcome now. So we'll have to wait and see how things are happening. So thank you so much, all the presenters. You did a great job. Thank you so much.
Thank you, everyone.
Thank you.
So just before we conclude, can we have everyone to open up their camera so that we can just take a group photo? Thank you. Thank you. I'll now pass this session on to Rolika.
Thank you.
Thank you.
Everyone.
Thank you everyone for the wonderful session and great inputs. And we will be holding the next session in the same. It will be just a second. I will.
Thank you and good
It will
day.
be on the allergies part, right?
Thank you. Good day.
Thank you. Thank you, everyone.
Thank you.
Bye.
Thank you.
Bye.